With ICSI, we're able to give sperm a really big head start, a really big boost, give them help to get to the egg, to fertilize the egg. But we know that those fertilization rates may not be as high as they are in people who are doing IVF where sperm parameters are totally normal. So it's still absolutely worthwhile to do IVF with ICSI because even if the chance of success is a little bit lower, it's way lower when we're talking about things like pregnancy by intercourse or pregnancy by IUI. Welcome to my fertility podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Hello again, superhumans, and thank you for joining us. Today, we're diving into a topic that is often overlooked, but really important. And this is fertilization failure during an IVF cycle. The WTF appointment is an informal but very appropriate term for a follow-up consultation that happens after an unsuccessful IVF cycle. Typically, when things don't go as planned or when patients are left thinking, what the actual F happened?
And for those of you who are interested in hearing about other components, things that may happen in WTF appointment, this is our second in the series. WTF Part 1 was all about what happens when you get less eggs than expected, and that was episode 62. And if you're listening to this and you're thinking, what the F is IVF, then you can have listened to episodes 14, 20, 54, and 58, where we get into the nitty-gritty of IVF itself.
So in this episode, we're going to explore why sometimes, even with egg and sperm in the lab, fertilization doesn't happen or doesn't happen as expected. We're also going to talk in detail about egg maturity and how it can affect the IVF outcomes, and in particular, fertilization outcomes.
I think this is going to be a really informative episode, and especially for anyone who's been through IVF or who's going to be going through IVF. So let's get started.
Let's start with the basics. Fertilization is a process where sperm penetrates an egg and combines its DNA with the egg's DNA to form an embryo.
In IVF, fertilization can be achieved in two different ways. There's conventional insemination, which is also sometimes called conventional IVF or just IVF, or a process called intracytoplasmic sperm injection, also known as ICSI, which we often call ICSI. In conventional insemination or conventional IVF, the lab will place several tens of thousands of washed sperm. In addition, they'll have a group of eggs, hoping that one sperm will naturally penetrate and fertilize each egg, very similar to what happens in the fallopian tube.
In ICSI, or intracytoplasmic sperm injection, is where a single sperm is injected directly into the egg by an embryologist.
There are pros and cons to each method of fertilization, to be very clear. Neither is, better, quote unquote. It really varies patient to patient. For instance, the sperm count and motility have to be at a certain level to even consider conventional insemination. For some patients, when we're planning an IVF cycle, we might not even be having much of a discussion about IVF insemination versus ICSI because we know that we're going to need ICSI. I think we should go into greater depth about IVF versus ICSI in a future podcast episode, Dr. G.
It's a great idea. Let's do that. So fertilization failure can be total, meaning none of the eggs fertilize, or it could be partial, where only a few fertilize, or not as many as expected.
Partial or low fertilization rates can be a bit more subtle, right? Sometimes patients are told, you had 12 eggs at the retrieval, but only 3 fertilized. And they're left wondering what happened to the other 9. It's worth noting that a low fertilization rate doesn't necessarily have an agreed upon definition, But generally, we're talking about a fertilization rate less than 30 to 50%.
That's where this discussion becomes really important in understanding the factors that may play a role in fertilization and why it doesn't work, even when everything seems to be right.
Now, before we talk about what's abnormal, I think it's really important to keep in mind what is normal and what we can expect. So, generally speaking, in an IVF cycle, the expected fertilization rate of eggs is typically about 60 to 80%, meaning that 60 to 80% of mature eggs that have been either inseminated or injected with sperm will show normal fertilization, which means the presence of two pronuclei or 2PN following day.
Fertilization failure, luckily, isn't very common, but it's also not rare. With conventional IVF, the total fertilization failure rate is estimated around 5 to 10%.
With ICSI, the rate is lower, usually around 2 to 3%, but partial fertilization failure is more frequent, and it can still impact cycle success. So even though it's not as dramatic, let's say, as a total fertilization failure, the outcome at the end of the cycle can still lead to no embryos.
Honestly, this is a real emotional blow to patients. Going through all of these hormone injections, the retrieval, the hopes, the dreams, and then nothing fertilizes is absolutely devastating.
And really often, patients feel like they did something wrong, which is absolutely not true. Fertilization is so complex, and there are multiple factors that can affect it.
For example, one of those factors is egg maturity. Not all the eggs that are retrieved during IVF are actually ready to be fertilized.
That's right. So, eggs go through several stages of development. Only mature eggs, which, if we go back to high school biology, thinking about meiosis, eggs that are in metaphase 2 or the M2 stage are capable of being fertilized.
Immature eggs, like those in metaphase 1 or vesicle stages, haven't completed the necessary steps for fertilization. They may mature later in the lab, a process called in vitro maturation, but unfortunately, success rates are much lower from the fertilization point of view.
So, if someone has 15 eggs retrieved, but only 7 are mature, that immediately reduces the fertilization potential by more than half.
And a lot of patients don't realize that. They hear, oh, we got 15 eggs or 20 eggs, and that's amazing. But what we really need is understanding how many of those are mature and usable for either conventional IVF or ICSI. And it's important to point out as well that we don't know about egg maturity immediately after retrieval. So the embryology lab is not going to know if an egg is mature or immature until following the day after the retrieval in some cases, if they're doing conventional IVF. If they're doing ICSI, they do need to strip the layer of the egg in order to put the sperm inside, and then they'll know if they're mature or immature at that point. But that happens hours after the retrieval. So right after the retrieval, the fertility doctor, all the information that they have is that 12 or 10 or 15 eggs were retrieved, and we don't know at that point how many of those are mature.
The rate of maturity is influenced by a lot of things, including the stimulation protocol, the type of trigger shot that was used, or if there's multiple trigger shots being used, the timing of the trigger shot to the time of the retrieval, and just the individual's biology. During a retrieval, we try and get as many eggs as we can safely. Even if a follicle looks a little small on ultrasound, we will still try and quote unquote poke them and try to find that egg, but we also know that eggs coming from smaller follicles are less likely to be mature.
Actually, I think it's important to mention at this point that women with polycystic ovarian syndrome or PCOS are at higher risk of retrieving immature eggs during an IVF cycle. This is due to the fact that they have a very high intrafollicle count, and part of having PCOS is that there is dysregulation of follicogenesis, which basically means that not all the follicles are going to grow at the same rate. So you're going to have a higher proportion of eggs that are being arrested at the germinal vesicle or in metaphase 1 at the time of retrieval, even if we do everything that we can to optimize the stimulation protocol. And if you want to know more about PCOS in the context of fertility, lifestyle, or IVF, listen to episodes 16 and 21.
At the end of the day, the doctor who's doing your retrieval is really trying to get as many eggs as possible to give you the best chance of success. Sometimes that might mean getting more immature eggs, but we know that there is still a chance of them succeeding. So, frankly, in my opinion, I think it's still worth it.
Yeah, absolutely still worth it because you don't know. At the end of the day, the more eggs that you get, the higher the chance that some of them are going to be mature. So I agree with you. I also try to get as many eggs as possible, even if the follicles are smaller.
What's interesting is that with immature eggs, so again, these GVs or M1s that are retrieved during a stimulated cycle can be matured in the lab, as we said, and that's called rescue in vitro maturation or in vitro maturation, and then they can be fertilized a little bit later. The fertilization rate for these in vitro matured eggs is generally in the range of about 60 to 70%, which is pretty comparable to mature eggs. But the subsequent embryo development and live birth rates are substantially lower.
So, what causes fertilization failure? Let's go through the major categories: egg factor, sperm factors, and lab related factors.
So let's start with the eggs. As we mentioned, egg maturity is important. Again, only mature eggs that are in metaphase 2 or M2 eggs are ready for fertilization. And generally, a low proportion of mature eggs is associated with reduced fertilization rates, embryo development, and lower live birth rates, meaning that we know that egg maturity is really important to be able to be fertilized.
Another factor is egg morphology or oocyte morphology. Morphological features such as the appearance of the first polar body, the presence of cytoplasmic inclusions correlate with fertilization rates. Eggs that have optimal morphology, like a perfect polar body and the absence of inclusions, have a higher fertilization rate and better embryo quality rates.
There's also other components of the egg that are going to affect fertilization, including the cytoplasm and spindle characteristics. Again, if we go back to high school biology and we're thinking about these spindles or these little like railings, let's say, that are connecting the genetic material in the egg, we know that abnormalities in that can also affect fertilization. Now, let's be clear, this can only be assessed by a really fancy microscope. It's called polarized light microscopy. And so we are not able to assess eggs in this way in an IVF lab. This is really a research tool. Basically, what we're trying to say is that there are lots of characteristics of eggs, some that we can see easily in the lab and some that we can't see that are influencing fertilization rates.
The follicular fluid environment is another factor that can impact fertilization rates. We are referring to the follicle is the little house that contains the eggs, and the follicular fluid is the fluid that is surrounding the eggs. So in this fluid, you can have stress markers or pro-inflammatory cytokines, and these have been linked to difficulties with egg maturation and lower fertilization rates. Again, unfortunately, IVF clinics do not have the ability to assess the follicular fluid outside of a research study. And also, to be clear, we're not suggesting that you have to eat more antioxidants or that reducing inflammation would necessarily fix a poor fertilization rate. Currently, there's just not enough information to understand the correlation between follicular fluid, pro-inflammatory cytokine levels, and oxidative stress level, and lifestyle modifications and diet and nutrition.
There's also something about the hormonal and metabolic milieu, so to speak, that's in the ovary and the follicles. So there's research to suggest that high concentrations of growth hormone, prolactin, interleukin-1, TNF alpha, and follicular fluid are associated with improved fertilization outcomes, suggesting that there might be some role for these factors when it comes to that final oocyte maturation step. Again, this is not well understood. We don't know how to influence these concentrations in follicular fluid specifically. So this is not a treatment recommendation by any stretch.
So we've been talking about egg-related factors so far, but of course, sperm also plays a role. So now we're going to talk about sperm-related factors that can affect fertilization rates in an IVF cycle. One of them, for example, would be sperm concentration. Lower sperm concentration, particularly if it is severe oligospermia, defined as less than 5 million per ml of sperm, is associated with significantly reduced fertilization rate in both conventional IVF and ICSI, even when oocyte quality is controlled through egg donation cycles.
And also, sperm motility can predict a poor fertilization rate. So, reduced progressive motility is a predictor of lower fertilization rates, even when we're able to use something like ICSI, where we can give sperm a really big head start, so to speak.
So, increased DNA fragmentation or chromatin abnormalities in the sperm have also been linked to lower fertilization rates and poor embryo quality, even when we're using ICSI.
And there's also just about the functioning of the sperm and how competent of the functioning of the sperm is as well. There are certain steps that a sperm has to go through in fertilization. So any defects in these things called the acrosome reaction or binding to the egg or oocyte activation can cause fertilization failure, especially in ICSI cycles. Now, again, these are things that we kind of know about, but we really don't know how to test for these things outside of a research setting.
I'm sure that you have heard a lot about the impact of female age in reproductive success. But as a matter of fact, male age also has an impact. So, advanced paternal age is an independently associated risk factor for reduced fertilization rates and poor embryo development, even when we're using high quality eggs, as in the case of donor egg cycles. And this could be related by age related decline in semen parameters, motility, and DNA fragmentation.
When we are thinking about an IVF cycle where there is male factor, where let's say the counts are low or motility is low, it's still worthwhile to proceed with IVF, especially with ICSI. Now, we know that, let's say, when the count is less than 5 million, the chance of conceiving naturally or even by something like IUI or inseminations is extremely low. With ICSI, we're able to give sperm a really big head start, a really big boost, give them help to get to the egg, to fertilize the egg. But we know that those fertilization rates may not be as high as they are in people who are doing IVF where sperm parameters are totally normal. So it's still absolutely worthwhile to do IVF with ICSI because even if the chance of success is a little bit lower, it's way lower when we're talking about things like pregnancy by intercourse or pregnancy by IUI.
Absolutely. I couldn't agree more. And another thing I want to mention here is we can measure sperm concentrations, we can measure sperm motility. We could measure DNA fragmentation, and we actually had a great episode with Dr. Jarvie, which are episode number 44 and 52. But ultimately, we can never really measure the sperm ability to fertilize an egg. So if the numbers are perfect, it doesn't guarantee that it's going to fertilize an egg perfectly. And if the numbers are poor, it doesn't say that it's not going to fertilize an egg. I think it's important to understand that these parameters can give us a bit of an idea what's going on, but ultimately we just don't know until the egg and the sperm are put together in an IVF lab.
It's also worth mentioning, apart from sperm and egg, there can also be lab related issues too when fertilization doesn't go very well. Very rarely, it can be something about the culture media or the temperature or even timing can affect fertilization. Now, thankfully, most labs have extremely rigorous quality control processes. So if there are any issues or concerns, they're caught immediately.
Yeah, exactly. And at Markham Fertility Center, our IVF labs are held to the highest standards. But unfortunately, perfection is impossible in biology.
There are certain patient groups, there are certain patient risk factors that we know are also at higher risk of fertilization failure, and it's worth mentioning here. As we sort of alluded to earlier, we know that patients with polycystic ovarian syndrome or PCOS have a lower fertilization rate compared to other patient groups undergoing IVF, despite the fact they typically have a higher number of eggs per cycle. This lower fertilization rate has been kind of consistently seen across multiple large meta analyses. So, large studies of lots of studies. even though the absolute number of eggs and mature eggs retrieved is higher generally in PCOS than in non-PCOS women.
Women with polycystic ovarian syndrome may also have issues with egg quality, and that could be due to oxidative stress, inflammation, metabolic abnormalities if there is also type 2 diabetes, a higher BMI, and all of these things can impact egg quality, competency, and the ability to fertilize and develop into an embryo.
Another group where we may see lower fertilization rates is women with diminished ovarian reserve. This could be women who have low AMH or maybe a low antral follicle count or advanced age. Generally, we're talking about those who are getting fewer than 5 eggs per cycle are at increased risk because low egg yield and potentially that poor egg quality are strongly associated with both low fertilization rates and the risk of total fertilization failure. For more information about decreased ovarian reserve, we did a whole episode on that topic, and that was episode 33 of our podcast.
Another group that is at increased risk for fertilization failure, it's coupled with abnormal sperm parameters, particularly after processing the sperm. If there is low sperm concentration or low motility, they could be, as we mentioned earlier, increased risk of fertilization failure, even if semen analysis was normal in the past.
Another risk factor, another group that may be at higher risk is patients who have a history of previous IVF failure or primary infertility are more likely also to experience fertilization failure in subsequent cycles. If something hasn't worked previously, it's more likely that it's not going to work again.
That brings us to the next topic on this episode, which is what can be done after fertilization failure, because ultimately part of the WTF appointment is coming up with a plan for what's next. So if a cycle ends in fertilization failure, the first thing that we do is review what happened. What method was used? Was it IVF? Was it ICSI? What was the size of the follicles? What was the trigger that was used? Was it due to an egg maturity issue? Were the eggs very mature but fertilization didn't happen? Either way, we review all of those factors to see what could be improved upon in a subsequent cycle.
Generally speaking, if conventional IVF was used and fertilization didn't happen or was very low rate of fertilization, we would usually recommend doing ICSI for the next cycle. That's often enough to overcome sperm-related barriers. In fact, there was a prospective study where ICSI resulted in normal fertilization in live births in patients who previously experienced total fertilization failure with standard IVF, where when they had couples and they repeated IVF without ICSI, they had persistent failure. So if you do another cycle and you switch to all ICSI, you have a really good shot of having good fertilization. All is not lost.
I think it's worth talking about the study that you're mentioning, Dr. Weiss, because it does provide a lot of hope when there is fertilization failure, which, as we talked about, can be really devastating. This study was published in 1999 in Human Reproduction, and it was a comparison between ICSI and IVF in couples that had fertilization failure in a prior IVF cycle.
This was really interesting, the way that they structured the study. So couples went and they did a second IVF cycle, and they randomly divided the eggs so that some of the person's eggs went for ICSI fertilization and some of them went for IVF fertilization. So theoretically, we can assume that the egg quality was equal between the IVF and the ICSI groups in each patient. Of the 143 ICSI eggs, 90% were normally fertilized. And then of those fertilized eggs, 80% developed into transferable embryos. And again, these are in people who'd had a previous total fertilization failure IVF cycle.
That's amazing.
And when they looked at those IVF fertilized eggs, there was no fertilization at all observed in those 85, they call them sibling M2 eggs, which were inseminated. This is very, very striking.
And to make it clear, these were couples that had a normal sperm concentration to begin with. And that's why the original IVF cycle was planned to be IVF and not ICSI. There was fertilization failure. And then they did a subsequent cycle and did the split of the eggs between the ICSI and the IVF group while still having normal sperm concentration parameters.
I gotta say, though, when I was looking at it, I was really thinking, I love the fact that at American Fertility Center, so many of us tend to do half IVF and half ICSI for first IVF cycles.
I agree with you. And that's why even when sperm concentration is perfect, I tend to recommend half IVF, half ICSI because I'd rather not have to do a whole new cycle if there is total fertilization failure with IVF.
Let's say we did an IVF cycle, but we already did ICSI, or it was the ICSI that failed. So fertilization failure recurs despite the ICSI. Then really that's where we need to look into both the sperm and the eggs in more detail.
There was an interesting study looking at what happens when ICSI fails. This study was published in 2014. They followed 16 couples and they looked back to see what happened to couples that had experienced total fertilization failure in the past. In these 16 couples, there were a total of 27 cycles that had at some point total fertilization failure. All of them were under 40 years of age, and in all of them, there were at least 4 or more mature eggs collected. They found that out of these 16 couples with total fertilization failure, there were 4 of them where this never happened again. So they had it once, and then they went on to have other IVF cycles that had good results and good fertilization. 12 couples, unfortunately, did experience fertilization failure again after a prior issue of no fertilization with ICSI. So what this shows is that the causes of fertilization failure can be sporadic. And even if you do have total fertilization failure with ICSI, it doesn't mean that it's always going to happen again and that it's impossible to have good fertilization outcomes in a subsequent cycle.
In a couple who has experienced total fertilization failure, even when they've used ICSI or intracytoplasmic sperm injection, there are some subsequent investigations and discussions that should be had. Very generally speaking, we're thinking about things that may be technical, we're thinking about things that could be egg related, and we're thinking about sperm related factors as well. But it's really, really important to note that there is no consensus on what should be done. Like, this is not something that you can look up in a textbook and get some sort of algorithm, or there's no guideline around this. What we're talking about is really just a potential framework and how to think about things. But of course, this is going to change as we learn more and more.
So, thinking about what these technical factors could be, for example, a detailed review of the ICSI technique and the laboratory conditions would be indicated. Technical errors of suboptimal laboratory condition can cause sporadic total fertilization failure. So, in a situation like that, we would review the procedure, the timing, the handling of the eggs, the injection technique. All of those things need to be reviewed with the laboratory director in every case of total fertilization failure to rule out technical issues.
We would also think about egg quality and egg maturity. We would think about the number, the morphology, or the appearance of those retrieved eggs, because we know that in general, getting a lower egg number, or when the eggs are not looking normal, when there's some abnormal morphology, we know that that can also be associated with total fertilization failure. Again, it's not necessarily a perfect explanation or a perfect answer, but it does give us some clues.
Now, besides technical issues and egg-related factors, one also have to look at, of course, at sperm factors. And a semen analysis or a sperm analysis beyond the standard semen parameters would be indicated. So in the case of total fertilization failure, one test that we could consider doing is a sperm DNA fermentation assay. Now, we talked about this in detail on episode 44, where we interview a urologist or a male fertility specialist, Dr. Jarvie, who went into detail about what a DNA fermentation is and how we use it in clinical practice. So I would encourage you to go back to episode 44 to give it a listen.
Another aspect that we may consider when we're thinking about total fertilization failure is the oocyte activation. Not just about the quality of the eggs, but are the eggs essentially functioning normally as well? And so if the eggs don't activate properly, fertilization can occur. And this can be evaluated by examining the presence of the second polar body and pronuclear formation in these failed eggs. Now, you can consider doing something called artificial oocyte activation with calcium ionophore in a subsequent cycle if it does seem that oocyte activation failure is suspected. Now, again, this is not necessarily a perfect fix for fertilization failure. And really, this just merits a bigger discussion with the embryology team and the lab director who had the opportunity to review the case and sort of see whether they feel like this could be beneficial, but it's something else that we may consider.
And at the end of the day, if you have looked at all of those factors, technical issues, egg quality or site activation, semen analysis and DNA fragmentation, and then it's repeated total fertilization failure, and if we think that the eggs and the sperm are the suspect and the cause is not correctable, ultimately the use of donor gametes might be discussed. And the last thing that we want to say about this is that it's important to remember that total fertilization failure does not mean it is hopeless. It is a signal that something needs to be changed. It's obviously very disappointing, but it just warrants a discussion with your fertility specialist about what things can be optimized for a subsequent cycle, even if that looks like looking at donor gametes.
Yeah, absolutely. I think at the end of the day, it's really about, we can still work together and still dream to build that family unit that you, or maybe you and your partner had always dreamt of. It might just take a very different route or a different road than you had expected. Talking about donor gametes and moving to donor gametes is a big deal for sure. And with fertilization failure, I think that it's particularly jarring to patients when it happens. But at the end of the day, obviously, everybody is doing IVF with the goal of making good embryos and having a successful pregnancy. But when things stop, when the cycle ends abruptly and very early on in the relative process of IVF, it's particularly jarring to patients. And a lot of them will say things like, I never even got a chance to do an embryo transfer. I never even got a chance to have embryos. I never even got a chance to try PGT. And I think it strikes me as being particularly challenging, especially challenging for patients. And it really, fertilization failure feels like a silent loss, right? Like you never even get to that embryo stage.
Yeah, it's like not even given a chance. It's like being taken out of the game before even having an opportunity to say your piece in a way.
Yeah. And it's frankly, the vast majority of the time, we're all blindsided by it. I'm trying to think of scenarios or situations in the past, but really, I don't think that there is very many situations at all where anyone could predict total fertilization failure. And so, many patients will feel blindsided. We feel blindsided too as the fertility physicians, and there's an element of guilt with that too.
Yeah, absolutely. And this is where support groups like Oasis Fertility Network or fertility counseling, and we have a number of resources on our website, marketfertility.com. It's really important because, like you mentioned, it is a loss and it is grief. And there is a lot of emotions that come with that. And those things need to be validated and need to be explored. And you deserve to have the space to do that.
Absolutely. And I think also, like we've said this before in many different contexts, but it's important to point out this is really nobody's fault, right? Even though people will feel this deeply, and many people may feel like it is their fault because, it was their sperm or their eggs that quote unquote failed, but it really is not.
Some final thoughts and takeaway from this episode. Exactly what you said, Dr. Weiss, it is nobody's fault. Also, that fertilization failure, while it is uncommon, is still a real possibility when you're doing an IVF cycle. And not all eggs are mature and capable of fertilization. That is not something that patients can control or that your doctor can control. And unfortunately, it's something that, like we talked about, it's unpredictable and one of the more uncommon but possible outcomes of an IVF cycle.
And even if a cycle does end in either very poor fertilization rates or total fertilization failure, it does not mean that all future cycles are guaranteed to fail either. There are studies to show that even if you don't necessarily change up anything, or if you move to ICSI, let's say, fertilization rates can be much better the subsequent time around in a subsequent round of IVF. Now, obviously, it's always difficult to imagine doing a second round of IVF after having a poor outcome in a first IVF cycle, but it's something that's really important to talk to your fertility doctor about as well. There are some ways that we can adapt the approach, but again, oftentimes we may not necessarily understand the exact whys and hows. But as is shown in this episode, very often the subsequent cycle does a lot better.
We hope that you're finding the WTF series helpful. And stay tuned for more WTF episodes where we're going to talk about other scenarios that make you think WTF and that you need to talk to your doctor about.
And that's a wrap for today, superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramirez C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.